I'd like to welcome Dr. Kush Desai, who is an interventional radiologist and professor now of radiology, surgery, and medicine at the Northwestern University. Congratulations.
Thank you.
His primary research and clinical interest are in venous thromboembolism disease, deep venous thrombectomies, thrombolysis, reconstruction of the iliac, occlusions, IVC filter, difficult filter management with complex retrievals, uh, PE management, and he serves as the chair for the SIR and uh, Venous Clinical Specialty Council. He's a fellow of the SIR. He also serves as a national and global principal investigator for numerous clinical trials worldwide. And he helps really, one of his fortes is really looking at deep venous disease. He's really been one of the leaders in this field. He serves as a reviewer for several journals, including Circulation, the Journal of the American College of Cardiology. He's a distinguished reviewer for the JVS VNL and a top reviewer for the Journal of Vascular and Interventional Radiology. He's authored over 100 peer-reviewed articles. So thank you for agreeing to do this podcast.
No, it's my pleasure and honor. Thanks for having me.
So with the increasing incidence of the iliac vein stentings worldwide, can you talk a little bit about its role with venous insufficiency and why it's increasing so much?
Yeah, I mean, I think there's this growing understanding and acceptance that maybe we haven't paid attention to deep venous obstructive disease or given it enough credit as a cause for patient symptoms as maybe we should have in the past. And particularly in my practice, it's on the post-thrombotic side where you can have patients that have post-thrombotic obstruction for years and they're simply told there's really nothing you can do. Put on a compression sock. And you know, um, there's certainly single center and small multi-center data sets that suggest that there makes a difference. And of course, we all look forward to C-Tract, which hopefully wraps up soon. And that's, for those that don't know, that's a National Heart, Lung, Blood Institute sponsored trial that my good friend Suresh Vedantam is running. That's an RCT, and if it's positive, that will be the single strongest piece of evidence showing the value of iliac vein recanalization, particularly in post-thrombotics. And so, with all these things kind of coming together, you we're finding that deep venous obstructive disease is certainly no longer a frontier. We're fully into it, and not only have practitioners paid it heed, but industry as well, in terms of iterating and innovating on new devices because there's certainly a compelling need.
I tend to agree with you. I think that some of the results have really suggested that fixing these patients' lesions really does improve quality of life and help heal their wounds, quite frankly. So yes, I tend to agree with you, and I think C-Tract will be an important contribution. We've seen a lot of different stents come up in the last 5 years, a lot of new stents. I wanted to talk about some of the new innovations in the upcoming stents also.
Yeah. So, the first for a long time we were practicing off label. And then the initial stent, which is of course the VG stent, was no longer available. And then the wall stent did get approval post hoc for iliac vein obstruction. And then of course the Venovo, and then after that the Abre and Silvervena. And so there are many devices that have been approved, and they're all good devices. They're specifically designed for the challenges of venous anatomy, both, the fact that it's curved, the appropriate sizes, delivery systems that are generally very friendly to use, and you know don't require a huge amount of experience that you need to bring to the table. Certainly, you need experience in the disease state and working these patients up, but not to deploy the widget, so to speak. But there are some newer devices that are currently in trial right now that answer a need that really hasn't been addressed yet. And that's certainly near and dear to my heart, as somebody that does a lot of complex uh, deep venous obstruction, post-thrombotic obstruction, particularly iliocable obstruction. And for years, we've been, I mean, for lack of a better word, cobbling together different devices to meet that need. And now we have a device that is in trial right now that hopefully we'll find is the first step in really addressing these patients with a purpose-built device for IVC obstruction.
So can you just describe what is this new device and what's the gap that it's trying to fill?
Yeah, so it's the device is called Viafort. The manufacturer is WL Gore. I have the distinct honor of being one of two global principal investigators on the IVC trial, along with my good friend Stephen Black. And in parallel, we're running an iliofemoral trial, also with a good friend of mine. That's a U.S. only trial with my other good friend Kathy Gibson. But focusing on the IVC side, because that's where there's the clear differentiator, is that this is a device that is designed to fit in the IVC. And for those of us that do this kind of work, we know that you don't usually just have IVC obstruction. You have concomitant iliac obstruction as well, if not full-on iliofemoral and cable obstruction. And so these are the most challenging deep venous obstruction patients, no question. The disease burden is very significant in these people. And as I said before, we've just been kind of trying to, for lack of a better term, jerry-rig devices to work with it. And now we have a device that is the size of the native IVC, and you have iliac limbs that specifically work with the cable limb. And so that's what this is going to answer, hopefully, which is that we have a device that we have modular components working together to treat bilateral iliac vein and cable obstruction.
So I think you were saying that this is a relatively new construct. Can you mention a little bit about what's it made of, besides being
Mhm.
modular and being specifically, what makes it different in terms of the construct?
Yeah.
It's nitinol, and what else is it made from, and how is it different?
Well, being a Gore device, of course, it has PTFE, but it's not a covered device. It's not a covered device. It's actually a device that has a nitinol coil and then has ePTFE bonded to it, and then the holes are drilled into it, laser drilled into it. So it's a closed cell device, but it is a perforated device, so to speak. And Gore has done a lot of work with testing side branch patency and all that, because that's, of course, the challenge that we deal with in cable obstruction that is not as much of an issue in the iliac side, certainly across the hypogastric, but there's a lot of work that was done on the bench, and now we're doing in the trial where is it okay to place this, for example, across the renal veins without worrying about renal vein obstruction, because it is a perforated device. Now, the cable sizes come in 20, 24, 28. And the idea is that if you use, for example, a 24, which is the most common cable size that I use, you actually can put two 14 millimeter Viafort stents inside of the 24, and you lose no aspect ratio whatsoever, meaning that they remain exactly circular. And the math doesn't quite add up, right? Two 14s is a 28, but when you're putting in a 24, that's we won't get into the geometry of it, but it works, and that's how it's meant to be. And if you're going to use a 28, you use actually two 16s. So but you have devices that are meant to work together, and it is a different device in that it has that nitinol core, and then it's ePTFE that's drilled. And then the other thing is that this is the first device that has the promise, whether that bears out into a clinical outcome or not is remains to be seen, of being able to simulate axial load, which is an important part of cable dynamics, right? It's not just expansion, it's also axial load that can come from different positions and respiratory motions and those kind of things.
Some of the proposed advantages of using this particular device as compared to the other devices that are already on the field. I mean, it sounds like a new construct, and it sounds like definitely a different design. The pictures look quite strikingly different than the prior stents in terms of the venous-specific stents that we have today. It sounds like not only have they designed it to be differently, but they have different goals in terms of trying to push the field forward.
Mm. Yeah, no, I would agree with that. So the one thing to remember, I think, the benefit is one, of course, we have a device now that was engineered for this perspective, for this specific purpose. There's nothing else but that's been engineered for this, right? Time, money, has been spent to design it for cable obstruction. That's the first thing. The second thing, and equally important in my mind, that this is that this is the first multi-center, independently adjudicated trial for cable obstruction. Everything else, including my work, is single center, right? Which brings the biases and all that kind of stuff that comes with it. And now we have a trial that is multi-center, subject to a DSMB, subject to a core lab, and I think this will probably be the highest level of evidence there is in the interventional treatment, the endovascular treatment of cable obstruction. So that's the other real benefit of this trial.
So this sounds really exciting, and this sounds like it's going to push the field forward. Where are we with this trial?
Yeah, so we're doing quite well. We're nearly enrolled, hope to be fully enrolled by early part of next year. And then we go into data lock and it gets analyzed, and maybe we get to hear some early results late next year.
This sounds really exciting, especially since it's from what little I've seen about it, it sounds like it's a whole new idea. It sounds like it's really heading in a different direction, which is, I think, something useful. Gore has a long tradition of engineering solutions that take the step forward, and I think using ePTFE for this may have certain advantages also that I think they've tried to design into this product. I'm not 100% certain where it's going to fall in terms of
Right.
which patients, but I could easily imagine that if you have something that pushes the field forward for these difficult patients with extensive thrombotic load extending sometimes beyond the renals, as you said, they can be quite challenging. And we do need better solutions because I'm not certain
Right.
the ones we have today are quite have the patencies that I like to see, quite frankly.
Yeah,
Um,
yeah, that's right.
uh, you spend a lot of time and energy, radiation, recanalizing these patients, and the patency rates don't seem to be as good. Maybe because some of the patients are prothrombotic and they have extensive disease, and maybe we don't have quite the right anticoagulants yet, or quite the right management yet. But I think part of it is going to be the stenting, using some stents that are specifically designed for this, because I'm not certain that we have what we need right now. So looking forward to the data. Thank you so much for this
Sure.
podcast. It sounds really, really good. Could you give some advice for some of the young trainees or early career specialists? You had a long career with research and clinical trials and really helping push the field forward, and you're really one of the stars in this field. Could you give some advice for some young trainees who may be interested in doing research or clinical trials or such?
Yeah, no, thank you. I mean, very kind of you coming from you. I'm humbled, but I'll tell you that one of the things is that there are a couple things that have been sort of the guiding stars in my career. And one is get really passionate about something because you're going to get good at it, right? I recognized there was a need to treat deep venous obstruction at my institution in a coordinated, very systematic manner. It wasn't really being done in that way holistically. And then the second thing was that then it was ripe for getting involved in clinical work and research and really pushing the field forward. And so then the substrate's there, right? I start doing my thing. And if you're passionate about it, you'll want to get good at it. That's the one and number one and number two. Number three is stay curious. The minute you stop being curious and the minute you stop thinking that is there a way I can get better, you stagnate. And I think if you stay curious and you find a like-minded community, which I've been extraordinarily fortunate to find a like-minded community in this, where there are people that are equally curious, that want to solve the problems, that fully admit we haven't gotten this all figured out, that there's still so much work to do to make this better, not only for ourselves, but most importantly for the patients. Um, that you all work together, and it makes it that much more fun, right? Um, so I'd say those are the big things. There's more, of course, but those are the big things that I would say that if you have those things, you're going to find yourself ending up being successful.
Thank you, Dr. Desai. This was really, really enlightening. I think this is going to be a really promising technology. And as I said, we're really looking forward to seeing some of the results of this study. I didn't realize it was so far along, but it sounds really, really good. And I think it'll really be a very promising trial.
Thanks so much. We look forward to presenting the results soon.